So Carrie, you can go ahead and let everyone in and I'll introduce Dr. McPherson.
Perfect.
So-
It's done. We're ready to go.
Okay, that's good. We have 22 people in the lobby. So seems it's working.
Admit all.
Admit all?
Yep.
Okay. Done. So I have me, yourself, Harry, and then even Hosa as the presenter.
Hey, good morning, everyone. Welcome to Wednesday morning cardiology rounds. This morning, it's my pleasure to introduce our own Dr. Ruth McPherson. She graciously agreed to present to us today. She needs a little introduction, but just as a reminder, she's the director of our lipid clinic and a leader in the management of dyslipidemia and atherogenomics internationally. So I'm looking forward to her presentation today and welcome her to give us an update on cardiovascular disease prevention and dyslipidemia.
Thank you. Thank you, Ellie. So today's a little bit of a review of the things highlighted in the 2021 CCS guidelines for lipid treatment and CV prevention. But I'm going to talk about a few new things, particularly in the area of PCSK9. We do have a new therapy, antisense RNA, inclisiran, that is a new and effective way to lower LDL cholesterol levels. These are my disclosures. So this is what we're going to cover today. Inclusion of LPA. So I think everybody's confused because everybody's getting LPA measured now. What do you do with that? And the other confusion there is that the units have kind of changed. I think in the past, all of the American literature, and we thought about LPA in milligrams per deciliter or grams per liter, whereas the measurements now probably more appropriate in terms of measuring particle numbers, nanomoles per liter. So I'll explain what the difference is there. But why do we want to measure LPA? What are we going to do with it? What does it mean in terms of prevention? I'll say a few words about primary prevention, and this is really simplistic. So my point of view, you have a 40 or 50-year-old individual who does not have clinical ASCVD. Is he or she a candidate for prevention? So I think the only important point there is that statins reduce the risk of cardiovascular disease, stroke, and heart attack, irrespective of the level of LDL cholesterol. So that the decision to treat with a statin is not so much what is the LDL, it's more what is the level of risk and what can I do to reduce that risk further. I'll also talk about secondary prevention targets. These are getting lower and lower as time goes by. And finally, high-risk hypertriglyceridemia. So we've had a lot of talk about the CEPA, IPE, isocosapentaethyl. When should we use this? How robust are the data suggesting that indeed this is a very useful therapy in terms of secondary prevention? Okay, so LPA. So certainly, I'm trying to figure out how to use my pointer here. One second. Here we go. It's been so long since I gave an in-person presentation that I don't even know how to use the pointer on the screen. Anyway, not to worry. Okay, lipoprotein A. The important thing to remember is got this funny skewed distribution. So the median for the population, we're now thinking in nanomoles per liter, is about 20 nanomoles per liter. So that's the median. And these are data for European white individuals. The distribution is different in African Americans. So the median is about 20. And as levels go up, and indeed it's only a few individuals who have these extremely high levels, there is a stepwise increase in the future risk of ASCVD. So when you see these lipoprotein A levels come in, nanomoles per liter, you know, it's those patients who are above 200 nanomoles per liter, which is equivalent to just under 100 milligrams per deciliter. Those individuals are really at increased risk. So the higher the level, the greater the risk. The data now are nanomoles per liter, and the only thing to remember there is that 50 milligrams per deciliter, which is kind of the level that the CCS guidelines highlighted as being definitely increased risk, is about 115 nanomoles per liter. So an important risk factor. And if you look at these are also data from the UK Biobank study as analyzed by Brian McPherson. The higher the level of LPA, the greater the long-term risk of cardiovascular disease. So you get these levels of LPA that are above about 350 nanomoles per liter. Lifetime risk of ASCVD, or the risk over about 30 years, is up to about 40%. So what do we do with it? It's really a way to assess risk. Now, in terms of whether we can lower LPA to reduce the risk of cardiovascular disease, we have 2 phase 3 trials underway. And these are both molecular therapies. One is pelacarsen, which is an antisense oligo from Novartis, and that's undergoing a trial. We did a phase 2 study of pelacarsen, lowers LPA by about 80%. And then there's an siRNA from Amgen called olpasiran, and that is also undergoing a trial. So the trials are in patients with an LP level greater than about 140 nanomoles per liter who have ASCVD already in statin therapy. And of course, like any RCT for a new therapy for cardiovascular prevention, the goal is to show that indeed this is of incremental benefit. So we may have those therapies available. So this is a European consensus, and in a sense, I thought it was clearer than our guidelines actually. But basically making the point that LPA should be measured in everyone at least once. So LPA it's basically 95% genetic. There are genetic variants close to the LPA gene that determine the level. There are 2 particular SNPs that have a very robust effect, but LPA levels don't actually change over lifetime, with the exception of the fact that PCSK9 inhibitors lower LPA by about 25%. And we also have the issue that measurement, particularly at higher levels, is not absolutely precise. So you may have a level of 300 nanomoles per liter on one occasion, and then 270 on another occasion. That probably doesn't make any difference, but you should measure at least once. When? Well, I think at the time of risk assessment. So you're basically using LPA as a way to assess risk. So over and above the other risk factors, if LPA is high, obviously that is an indication to start earlier treatment. What we've also learned over the course of the last few years is that LPA is a very robust risk factor for aortic valve calcification, aortic stenosis. And there is another trial underway to see if lowering LPA will have an effect there. Probably not when we're talking about a calcification process, but it is something to be aware of. Even though in the past we thought, well, because the little a component of LPA is competitive inhibitor of plasminogen, we thought maybe this is a prothrombotic risk factor. Sort of it is, but it's not really associated with venous thrombosis. So that was an idea in the past. It doesn't really seem to be true. Okay. So first of all, a few words about primary prevention. This is the simplest way to look at it. So a 40-year-old man, a 50-year-old woman without known ASCVD, when do I think you should consider statin therapy? LDL is above 4.1. I'm saying 4.1 and not 5.0. Non-HDL above 4.5. Non-HDL being really a better marker of risk than LDL because it incorporates the cholesterol in LDL, also the cholesterol in the triglyceride-rich particle. Coronary calcium score, any coronary artery calcification is an indication of underlying plaque, And in a 40-year-old, the CAC above 0, you have to be aware that the process of atherosclerosis is underway. And finally, LPA. I mean, this is a bit arbitrary, but an LPA, I think, greater than 230, even in the absence of other risk factors, definitely a higher risk individual. So in all of this, I still have lots of patients referred to me with an LDL, sky high, 5.5, but an HDL2, and the family doc says, well, the LDL is high, but the HDL is great. We don't have to treat. And of course, years ago, we did put emphasis on the total cholesterol to HDL ratio. That really is quite inappropriate because the association of high HDL with decreased risk was based on the first cohort in the Framingham risk factor study, and bigger studies, and these are data published many years ago, 2009, from the Emerging Risk Factors collaboration. But really what you see here is that for patients who have an HDL of 1.3, that's probably when risk is lowest. So a low level of HDL is associated with risk, probably in part related to association with other risk factors, although it is there even if you correct for other risk factors. But once you have an HDL greater than 1.3, there's no further benefit. So HDL2 doesn't really protect. So we kind of ignore the HDL and focus on the LDL, or more specifically, the non-HDL shown here. And as non-HDL goes up, certainly the risk goes up significantly. So why a 4.1 rather than 5.0 for a patient that may be considered low risk? These are data from the Hooper Center longitudinal study. So huge study, 36,000 individuals followed for over 30 years. And really what you see here for both total cardiovascular disease or coronary artery disease is that the risk goes up with the LDL, but you see an LDL of 4.1, risk is way up there, the same as 4.9. So I think you really should be thinking about lower levels of LDL to initiate treatment in early middle-aged individuals rather than waiting until the LDL is above 5, which is still sort of in the guidelines. Then what I tell family docs, I mean, kind of a simpler approach, and here the HOPE-3 study, which was, of course, a slightly older individual. So HOPE-3, lovely study out of the McMaster group, an international study, 12,705 individuals, no history of cardiovascular disease. Half of them were women. So men 55 or older, women 65 or older. They only had to have one cardiovascular risk factor. So it wasn't based on LDL or anything else. And the risk factors were fairly soft. I mean, anything from abdominal obesity to a low HDL to hypertension. And they were then randomized to placebo or a small dose of medication, rosuvastatin 10 milligrams, which is really very benign level of statin therapy. The important point to point out here is that the baseline LDL is 3.3. So these patients didn't have significant hypercholesterolemia. But as you see here, over the course, it was a study that went on for 7 years. Very significant decrease in all of the major cardiovascular events. I mean, stroke went down very considerably. The need for coronary revasc shown here, really extremely important effect, the risk of myocardial infarction. So definitely benefit. And I think the important thing to point out, and I say this to patients all the time, is that the benefit of statin therapy is related to the life years of treatment. So the longer you treat an patient with a statin, the greater the benefit. So it's not simply treating them until their LDL is down to something that it seems to be acceptable. Okay, so I'm going to talk about secondary prevention. The CCS guidelines, these were the areas of focus, the role of non-statin therapy, so particularly PCSK9 inhibitors. What is the most appropriate threshold? So the only thing that was different here is that we used to say, well, the highest risk individuals target a LDL of 1.8. Now the guidelines are stating that in a high-risk individual, so these patients with cardiovascular disease, particularly recent events, if their LDL is 1.8, then they're a candidate for addition of therapy. So it's less a target, more a threshold for adding something to get their LDLs lower. The guidelines also emphasize two things. First of all, over-the-counter omega-3 fatty acids are essentially of no benefit. And in fact, the issue with those OTC supplements is that they often contain oxidized lipid, saturated fats, so that even if they're ultra pure salmon oil, they're probably not good for the patient. But the guidelines did talk about icosapentaethyl, and I'll say a bit more about that in a few minutes. So obviously atherosclerosis, I mean, it's complicated, but overall it's an inflammatory response to cholesterol accumulation in the subendothelial space. How does that cholesterol get there? Well, via atherogenic lipoproteins, so LDL and the smaller VLDL particles that can also cross the endothelial barrier. So inflammation is a response to that. Inflammation is important, ergo the potential role of colchicine in many of these patients. But have to remember, a Russian pathologist way back in about 1914, 1909, did these studies with rabbits. And rabbits are very much like humans in terms of their lipoprotein profile. So they have LDL levels similar to man, HDL levels similar. So they're quite different than a mouse model. And you feed these little critters cholesterol and they develop very significant atherosclerosis, very analogous to the human situation. And as Anishkov showed, without cholesterol, they didn't get atherosclerosis. So cholesterol isn't everything, but certainly it is important. And this is why it's really the targeted treatment. So in terms of our guidelines, I was with three other, because in the old days when we wrote guidelines, there were only four of us. That made it really easy to write guidelines in 1905. But you know, the first guidelines, the LDL target for patients with ASCVD was less than 2.5. We thought that was pretty good. We thought it was good because after the CARE study, people like Frank Sachs said there's no benefit in lowering LDL below 3.5 because 3.3 because that's where patients got to in the CARE study. But 2.5 in 2003, a few years later, we thought, well, you know, lower is better based on some of the more recent data, less than 2. The guidelines 2013, 2016, we said, well, less than 1.8 in the highest risk. So most recent guidelines, 1.8 is the level where you consider additional therapy. And of course, these data are not, for the most part, very new because in 2004, the Prove It study was published. And that was long before these new guidelines. And Prove It, of course, was pravastatin 20 milligrams versus atorvastatin 80. That study showed that for patients that got LDL below 1.0, in fact, below 0.6 millimoles per liter, really the greatest benefit. So we've had these data available for quite some time, long before the era of the PCSK9 inhibitors. Okay, lipid-lowering therapies. Obviously, statins still cornerstone of prevention. Ezetimibe, a cheap drug, lowers LDL 15 to 20%, but ezetimibe is kind of an interesting drug because some patients have very little response. Other patients will get up to a 30% reduction. So it's really based on some of the genetic gut polymorphisms that affect the cholesterol transporters in the intestine, but still useful as an add-on. But of course, not all patients get there with statins plus ezetimibe. So we particularly focus on those individuals at the highest risk for ASCVD. So a little bit less concerned about a patient who's had single vessel disease, maybe angioplasty stent, everything else that's good in their arteries. That patient is not at the same risk as someone with 3 vessel disease, recurrent events, recent bypass surgery, particularly with saphenous vein grafts. Then we have those patients with severe familial hypercholesterolemia. So we now treat FH from an early age, in fact, from the age of 10 or 20 in severe FH. So if you treat these patients early and get their LDLs down to the population mean, they're really at no higher risk than anyone else. But FH is of particular importance when this patient comes in at the age of 40 with an anterior wall MI, didn't know his cholesterol was high, was never treated. So at that point, obviously, very high risk, and you really have to get the levels much lower. So lowering LDL, I mean, this is simple. What we've had for years and years are these small molecules and simple structure. They usually target enzymes and receptors. So in the lipid field, we're thinking of statins and acetylide. So these are good drugs. I mean, they do have possible off-target effects, safe drugs, but you know, I do see the occasional patient with statin-induced myositis. I see a few cases of statin-induced rhabdomyolysis, usually in the background of an elderly patient, comorbidities, particularly chronic kidney disease and diabetes. So, you know, there's a bit of caution with statins, although across the board, they're generally safe drugs. Then we have the large molecule proteins and antibodies. So here, obviously more complex, more expensive to make these agents. They generally either target receptors or target protein-protein interactions. So in the lipid field, the two PCSK9 inhibitor monoclonal antibodies, evolocumab and alirocumab, so Repatha and Praluent, fall into that category. So what's new? RNAi therapies. So RNA interference, these molecules bind to RNA to really in the end affect gene expression. So the RNAi targets specific messenger RNA to selectively prevent synthesis of a protein. So what we have available now is inclisiran or Leqvio. And so it's an exciting new therapy and simpler to administer as compared to the monoclonal antibodies. So genome editing, I mean, this is the future, but it's underway. So there is a company led by St. Catherson called Verve. So there is a compound called Verve 101. And this is a lipid nanoparticle formulation of messenger RNA to code for the CRISPR enzymes that are going to selectively eliminate a single nucleotide in the PCSK9 gene. So really very targeted, and it's not simple chemistry to have developed this, but this compound, Verve 101, has been tested in non-human primates, appears very, very safe and certainly lowers LDL very significantly. And there actually is a human trial underway. So the difference between genome editing and antisense RNA or siRNA is that this is an effect that lasts over about 6 months, really solely directed at the liver, whereas the genome editing is going to affect all the PCSK9 produced in the body. Is that important? Well, we know there are individuals who are completely deficient in PCSK9 because of 2 null mutations in the PCSK9 gene, and they seem to do perfectly well, but we'll see what the future holds there. So I won't probably don't have to go over this in great detail, but just the small molecule inhibitors, really the statins competitively inhibit HMG-CoA reductase to reduce intracellular cholesterol. That in turn will upregulate the LDL receptors. Then we have the monoclonal antibodies that basically bind PCSK9 and bind to the LDL receptor PCSK9 complex, and that prevents the degradation of the LDL receptor. And then we get into these newer and really quite exciting therapies. So statin monotherapy, I mean, we have to remember this is really effective. So rosuvastatin 40 milligrams will lower LDL by about 60%. So that's the same as a PCSK9 inhibitor. Statins probably have additional benefits. They're anti-inflammatory, anti-thrombotic. So for example, statin therapy lowers hsCRP as a marker of inflammation, whereas PCSK9 inhibitors do not. So I think even in those patients that need a PCSK9 inhibitor, there's always a rationale for concomitant statin therapy. For patients who don't tolerate the big guns like rosuvastatin and atorvastatin, we do have other statins that are less effective, but probably better tolerated by some patients. Pravastatin, for example, taken at bedtime, half-life is about 90 minutes, so it's gone from the body by morning. Pravastatin is not lipid soluble, so it doesn't cross the blood-brain barrier, doesn't get into muscles, so theoretically should not have any side effects. And of course, statin-associated side effects are difficult to deal with and sometimes most of the time they're not real, but the patient is convinced they're real. And so this is what I deal with in the lipid clinic all the time. And of course, every time you double the dose of a statin, you get another 6% reduction. So, you know, if we're thinking about what we can do for these patients, I think we have to remember that even the statin trial showed that for those individuals who achieved an LDL down to about 1.6 millimoles per liter, 90% of these individuals had slow regression or reduction in peak atheroma volume just with statin therapy alone, so that you can do very well with a statin, and it's not every patient that needs something else. So for the PCSK9 inhibitors, we have obviously very good data in terms of efficacy, in terms of reduction in MACE. The big issue has been cost and coverage. So, and I think the difference between the PCSK9 trials and the statin trials is that we're now able to achieve these super low levels of LDL. So in the Fourier trial, patients already on maximally tolerated statin therapy, addition of evolocumab, and shown here, patients on evolocumab and Repatha in red, they achieved LDL levels down to mostly between 0.5 and 1.0. The lower the LDL, the greater the benefit, and indeed the lowest incidence of recurrent MACE for those individuals achieving an LDL below 0.7. The concomitant Ebbinghaus study did not show any evidence of detrimental effects in terms of cognitive function, memory, or anything else. And of course, patients who are on the placebo events, even though LDL didn't look all that bad, greatest events in patients at the highest levels. So good evidence that lower is better. And of course, once again, intravascular ultrasound demonstrated that these patients getting down to LDLs, 0.6, I mean, the vast majority had regression, greater regression with lower levels. That makes sense. It isn't really a regression of atherosclerosis. Really what you're doing here is stabilizing the plaque because you're reducing the amount of soft lipid. So, of course, these agents are expensive. They're a little bit of a burden for the patient. Which patients really need a PCSK9 inhibitor? I think if we look at the post hoc analysis from Fourier, these patients already on maximally tolerated statin and ezetimibe, average mean baseline was 2.4 millimoles per liter. The follow-up here was only 36 months, but we do now have longer follow-up. So where we see the greatest benefit are those patients who've had a recent MI, those patients who've had 2 or more prior MIs, those patients with multivessel disease. So those patients with multivessel disease, you get down to a number needed to treat over this period of time, 29. So it really makes that therapy probably cost effective. So those are the patients that really benefit the most. In the Odyssey outcome study, that was with alirocumab, they had a pre-specified post hoc analysis according to LDL, and I guess it obviously it does make sense. Those patients who had an LDL above 2.6 millimoles per liter had the greatest benefit. So we'd like to give these drugs to everybody, but those are the patients that need it most. There was a recent paper published in BMJ Open, really criticizing the outcome, the analysis of the Fourier study. I don't think it was a very good analysis. It was from this group in BC. And there's a group at UBC in pharmacology and therapeutics. Years ago, they had a number of articles stating that there was no benefit to statin therapy. Now the same group has tried to reanalyze the Fourier study, saying that, well, we don't agree with the analysis. We don't really think there was any benefit. Well, obviously, we do have 2 studies. We have Fourier and we have Odyssey outcomes, but we now also have long-term data from the Fourier study. So really, this was published in CIRC just a couple of months ago. So these are patients who'd been in the Fourier study, and there are over 6,000. So they completed the first 3 years. and it included patients who had been on evolocumab as well as those who'd been on placebo. So they then were all put open label on evolocumab, and there was a 5-year follow-up. So if you look at these slides here, the in red are those individuals who had been on placebo and then went on Repatha. In blue are those patients who'd been on Repatha for the Fourier study, continued on it. So first of all, you see continued benefit, and clearly the longer you've been on a PCSK9 inhibitor, the greater the benefit. But although the Fourier study and Odyssey were not powered to get a mortality effect over a 3-year study, now that we have much longer term data, there actually was a significant reduction in cardiovascular mortality, cardiovascular death. So obviously evidence that indeed there is long-term benefit. Okay, so inclisiran. This is a small interfering RNA. It is one of the problems we had with the earlier siRNAs. For example, there was an siRNA against ApoC3 to lower triglycerides, which was effective, but had this off-target effect of thrombocytopenia. So inclisiran and the newer siRNAs have been conjugated at this GalNAc conjugation. That means they're directed specifically to the liver. So really this reduces the risk, well, it obviates the risk of having any effect of PCSK9 in other tissues. There have been chemical modifications that make this siRNA not only targeted to the liver, but resisting degradation by liver enzymes. So this is a double-stranded siRNA that basically binds to the messenger RNA and directs it to the RISC complex. So really what we're doing here is preventing production of PCSK9 in the liver. So the things I want to point out here is that there's absolutely no effect on synthesis of other proteins. So this is a way to have really directed therapy, and no effect on PCSK9 production, non-hepatic gut tissues. In the studies carried out to date, the Orion studies, no signal whatsoever for hepatotoxicity. So why is it a advantage is complementary to the monoclonal antibodies? It's really related to the dosage regimen. So patients receive their first dose subcutaneously of this siRNA at baseline. There is another dose at 3 months and every 6 months thereafter. So a very simple protocol for the patient. I have a lot of patients who've been on a PCSK9 monoclonal for several years, and they're pretty tired of these Q2-week injections. They also have these nice pens that they throw away every time they use it. So this, it certainly is a simpler regimen. The therapy lasts for basically, 6 months to a year. It doesn't last forever. If for some reason we decided maybe you do need PCSK9, which is unlikely. So we've had a number of trials underway. The Orion 9 study, patients who had heterozygous FH and LDLs above 2.6 at baseline. Orion 10 were patients with ASCVD, and this is a fairly big study, over 1,500 individuals, had to have an LDL above 1.8. Orion 11 went beyond ASCVD to include patients who had risk equivalents, so particularly type 2 diabetes or heterozygous FH. So these studies have been published. Overall, this is what we get: a nice decrease in LDL, a little bit smaller than a monoclonal. So agent like Repatha or Praluent will lower LDL by about 60%. You get about 50% with inclisiran, but still a very substantial additional LDL lowering. And in terms of the safety data, which have been published, really there's nothing here to comment on at all. Injection site reactions to a certain extent, but really nothing, nothing significant in terms of side effects. And really, there's been no evidence of any effect on liver function, transaminase levels, etc. So, do we have cardiovascular outcome data? Not yet. So there's a bit of an argument here because, you know, PCSK9 inhibitors were approved without CV outcome data, approved based on the fact that LDL is a surrogate for future ASCVD risk. And one will assume, obviously we're waiting for the study, but one assumes that there will be similar benefit. But big study underway, this placebo-controlled phase 3B trial. And that actually started 4 years ago. It's probably going to be completed July 2026, we expect. And basically, the goal is to show that there is additional CV benefit in patients with ASCVD already on statin therapy. So where do we stand in Canada with inclisiran? So inclisiran has been approved by the FDA in the States. It's available through Medicare, so totally approved in the States. In the UK, it's been kind of slow to approve drugs. It was approved by NICE quite some time ago, and it's approved by the NHS, so available there. And similarly approved by the European Medicines Agency. So in Canada, we've been kind of stuck. It's approved by Health Canada. So Health Canada is very happy with the data that are available, but not approved by CADTH. Now, CADTH is a really funny organization. It's kind of difficult to understand how they operate, but CADTH did not approve inclisiran. Really, the argument was, well, we already have monoclonal antibodies, so we don't need this. The other was that, well, we don't have outcome data, but they approved monoclonals that outcome data. So unfortunately, because it's not approved by CADTH, it's not available through ODB. However, inclisiran is made by Novartis, and Novartis will cover the residual cost of inclisiran for any patient with some private insurance. So there's a bit of a benefit there because I have patients who have a drug plan that covers 50%, that will cover a maximum of $1,500 a year, that sort of thing. So it means that if a patient has any private insurance, we can get full coverage. So, I mean, that is an advantage. And how do you do this? I have these are in the clinic. You have to fill out this form. It's actually going to be simpler than with the monoclonal antibodies because you fill out this form and then, you know, we're not really getting much. Once it's approved by the drug company and approved by the payer, there isn't really a lot of paperwork. So basically fill out this form, you have to give an LDL level. You don't really need a lot of data for this form. They either have to have ASCVD with an LDL of 1.8 or higher, or have FH with an LDL of 2.5 or higher. So really very simple. And so fill out this form, the patient's directed to one of the Coverdale infusion clinics. So there's one in Robertson Road, another in Saint Laurent, there's one in Gatineau. And basically the drug is administered there. So 284 milligrams at baseline, 3, then every 6 months thereafter. So really fairly simple. And for a patient that doesn't like to do injections, it's obviously much simpler than doing the injections of Repatha or Cadmium cells. Okay, so LDL, obviously important target of treatment. Lowering LDL reduces the risk of cardiovascular disease in everyone with or without ASCVD, irrespective of the level of risk or the level of LDL. And I think, you know, we do have some new therapies coming along, and I'm sure there will be more in the future. So I want to say a few words about hypertriglyceridemia, which it's really more of a therapeutic challenge because we don't really have good drugs. Triglycerides, of course, respond very well to lifestyle therapy. You know, you see a lot of these patients who come in with recurrent pancreatitis that's really been elicited by alcohol intake, resulting in chylomicronemia, or not resulting in chylomicronemia, but certainly the lifestyle factors are important. The risk for pancreatitis is really if triglycerides are greater than 18. Of course, the patient may have a triglyceride of 10 and go on a drinking binge and the triglycerides are then 40. So a baseline of 10 doesn't mean it's a safe level, but certainly it's these very high levels that cause chylomicronemia and pancreatitis. So clearly there's an indication for fibrate therapy. So mainly fenofibrate is the one we use most in severe hypertriglyceridemia. Triglycerides and ASCVD risk is complicated. So clearly, triglycerides are a causal risk factor for ASCVD. We know that from the Mendelian randomization studies, but the problem is we have not shown clear benefit for adding a fibrate to statin therapy in those patients who have mixed dyslipidemia. So they are not running around triglycerides at 10 or 18, but running around triglycerides of 5 or 6. You think, well, adding a fibrate should be a benefit because triglycerides are a risk factor and lower non-HDL a little bit. Well, in actual fact, we don't have very good data. So the earlier studies, Accord, a lipid lowering arm, being one of the most important studies, didn't show a benefit of adding fenofibrate to a statin. The argument of those earlier fibrate add-on studies was that they were carried out in patients, for example, who had diabetes, but didn't have significant hypertriglyceridemia. This is why this recent study that was recently published in New England Journal, it is out now, with pemafibrate. So pemafibrate is a new fibrate from Japanese company. It has this advantage over fenofibrate in that it does not increase creatinine levels. So the effects of fibrate on creatinine levels has been, a real problem. You have to use much lower doses in patients who have renal insufficiency or not use it at all. So certainly that was an issue. So this study was carried out in patients who actually had hypertriglyceridemia, already on statin therapy. And this is sort of a nice fibrate. So over the course of a 4-year study, there was a significant reduction in triglycerides. Although, and I think maybe this is the important point, although triglycerides went down, non-HDL didn't. So that was because as you added this fibrate to statin therapy, triglycerides went down, but LDL actually went up slightly. That's because the conversion of the triglyceride-rich particle, VLDL to LDL, is increased as the triglyceride content of the LDL is decreased. So non-HDL didn't change. So maybe this tells us that we shouldn't even think about triglycerides. We have to think about non-HDL. So overall, no benefit. So I think, really the idea of fibrate combination therapy is more or less dead, other than for those patients where the triglycerides are a risk because of pancreatitis. So the guidelines, going back to November 2021, the guidelines recommended with pretty high quality, they considered high quality evidence, the use of icosapent IPE or Vascepa to lower the risk of CV events in patients with ASCVD or diabetes and at least one CVD risk factor who had a triglyceride of 1.5 to 5.6. Well, 1.5 is actually pretty low in my clinic because I also got despite treatment maximally tolerated statin therapy. So this study, of course, this recommendation was based on one study, which I don't think we should ever make recommendations based on one study, but the REDUCE-IT study. Okay, so that was published New England Journal of Medicine, January 2019. Really a lot of hoopla because we didn't really expect this outcome. So REDUCE-IT patients who, this is what's in the CCS guidelines, ASCVD or diabetes plus one other risk factor, trigs above 1.5. And there was this very remarkable apparent decrease in MACE. It occurred not in the first year, kind of after the first year of treatment, but it certainly was significant. The relative risk reduction was about 25%. Number needed to treat was 21, which looked pretty good. This agent, however, didn't really lower triglycerides much. There's about a 20% reduction in triglycerides, but there were other increases. I mean, the real concern with this study was the placebo. So it was either IPE 2 grams twice daily or a mineral oil supplement 2 grams twice daily. So that has turned out to be a little bit problematic. The other thing that occurred really shortly after was the strength study. So the strength study was a little bit different in that it was 2 grams twice daily, not a purified EPA or eicosapentaenoic acid, but a combination of EPA and DHA. And that study used a corn oil placebo, which is probably a more appropriate placebo, and there was absolutely no benefit. So the reduced investigators and people like Preston Mason, who've been very keen on the fact that there may be some particular benefit of EPA, the eicosapentaenoic acid, simply because it has different effects in cellular membrane. So the EPA is more appropriately intercalated into the plasma membrane, whereas the DHA sticks out a little bit. So that plausibly might make a difference. So then the strength investigators went back and determined, well, we forget about DHA, what about the level of EPA? And the level of EPA did not indicate any benefit whatsoever. So it really sort of called into question whether or not the EPA per se was of significant benefit. And then more recently, we had this trial published, this post hoc analysis of REDUCE-IT published in Circulation. And really looking at, because the idea was that the CEPA should be beneficial because according to the laboratory and animal studies of Preston Mason at Harvard, it has an anti-inflammatory effect. So if we look at what happened in the REDUCE-IT study, across the board, the CEPA IPE is shown in blue. There was a very small decrease in CRP. So obviously statins will lower CRP by 30%. Colchicine has a greater effect, about a 20% reduction, but very little effect on, pardon me, sorry, early in the morning. Okay, we look at the inflammatory markers, CRP, interleukin-6, etc. So a small effect here. The mineral oil supplement actually increased all of these inflammatory markers. So a very significant increase in CRP, significant increase in IL-6. And IL-6 is kind of considered one of the more causative inflammatory markers in terms of atherosclerosis risk. There is also an increase in that should be IL-1 beta, slight increase in oxidized LDL, increase in LP-PLA2. So really calls into question the benefit of IPE in this study if the mineral comparator had a really pro-inflammatory effects that might in part have resulted in a higher event rate there, making the IPE arm look better. So I think we're a bit confused by these data. I'm not, there may be some benefit of icosapent ethyl. I think the benefit, if there is a benefit, is much less than we saw in the REDUCE-IT study. And the issue there is that this is an expensive drug. It's about $300 a month. And that's because, well, I suppose it's expensive to make because they basically have to purify the IP, etc. But we really need another study with an appropriate comparator to really make a decision as to whether or not this is a benefit. So I don't prescribe a lot of IPE. It doesn't have much effect on triglycerides and possible but questionable benefit for patients. Okay, the last couple of minutes, I'm just going to say something about colchicine. So colchicine wasn't in the guidelines. I don't know why it wasn't in the guidelines because I think it should have been. And obviously, inflammation is part of the story. So, you know, we've had a number of ways to reduce inflammation, everything from interleukin-1 inhibitors, canakinumab, that was a benefit for cardiovascular events, but so powerful that there was an increase in infections and, you know, very expensive. So canakinumab has never gone anywhere. But basically, what colchicine is a microtubule polymerization inhibitor. So basically prevents the NLRP inflammasome from being activated. So I'm going to tell these, but I would make a more, methotrexate is anti-inflammatory, but really little effect. So the methotrexate study was negative. So colchicine, you know, we've had some nice studies. Solidoko 2, patients with stable coronary disease. The COP study, patients with ACS and evidence of CAD managed with PCI or medical therapy. Colcott and Solidoko 2. So Colcott was, you know, acute ACS study, MI within 30 days. They had completed any planned PCI or high intensity statin. The report on extended release colchicine 0.5 milligrams versus placebo, and composite events were zipped. So, you know, very significant effect on events over a, you know, a fairly rapid effect that goes along with something that has an anti-inflammatory effect. But those data really did look quite nice. And this is post-hoc analysis, but for those patients treated early, there seemed to be an even greater benefit. So within the first 3 days, probably when CRP levels are highest, when inflammatory state is probably very important in terms of recurrent events, plaque stabilization, etc. There appeared to be a significantly greater effect. So that's for acute ACS, and I don't know to what extent colchicine is used. Patients who come in to the cath lab with, I know some patients end up with colchicine, but a lot of them don't. But I think obviously that study is important. Probably more important moving forward is the Solidoko 2 study. So these are patients who had stable CAD and a kind of loose guidelines. So they had to have any evidence of atherosclerosis angiography or simply a coronary calcium score greater than 400. They didn't have to have really complicated imaging. They had to have been stable for at least 6 months. They were put on this low dose colchicine, and Solidoko 2 showed a really significant and very nice effect in total events. This study went on for a total of a 5-year period. And these are the key secondary events. And finally, we have this study published in Circulation just a few months ago, going over, seeing what happens in the first year of that study. So this is stable CAD, year 2, year 3, and you get towards the end of the study. So from 3 years to 5 years, I mean, this is a huge difference in events. And admittedly, by the end of the study, the number of individuals were smaller just because of when they were recruited, but really suggesting that indeed there may be benefit. So, slide here. Because I had too many slides to do that. So colchicine, I want to make just a couple of points there. Colchicine is safe with high dose statin therapy. So patients on atorvastatin 80 or rosuvastatin 40, there really is no concern whatsoever. Obviously, patients who are in higher doses of colchicine, there may be. We do have to reduce the dose or avoid in patients with chronic kidney disease. So if you have a patient who has an EGFR of 30 or 40, instead of using 6.6 milligrams or 0.5 milligrams every day, go to Q2 days or half a tablet a day. Otherwise, really very well tolerated. A few patients will have gastrointestinal side effects, but most patients are able to live with that. Although we generally prescribe the colchicine 0.6 milligrams, it's about 25 cents a day. The extended release colchicine, Myinfla, that was used in these studies is better tolerated because it's extended release. It's 0.5 milligrams. The cost of that is about 50 cents a day, so there's not really too much difference. But I think if a patient doesn't tolerate OTC colchicine 0.6 milligrams, it makes sense to prescribe the extended release. Okay, I'm going to stop there. We've got a few questions. Oh, yeah. Fire and forget approach to statin use. Well, you know, in primary prevention, it kind of makes sense. because, you know, you can go by the HOPE-3 study, middle-aged, risk factor, just put them on rosuvastatin 10, it sits a benign dose, you won't have to worry about it. You could also think of the Jupiter study where they actually used 20 milligrams and there seemed to be even greater benefit. So in a sense, it's not a bad idea. So the fire and forget approach is not bad. The reason for doing repeat levels or any monitoring is just so the patient stays on therapy, because a lot of patients, well, they got bored taking the rosuvastatin long term. So you do the blood work and, you know, that encourages them. So I think treat fire and forget is really not bad. It's been sort of the British approach. And you know, I think it's reasonable. It may be necessary given that many patients don't have a family doctor and they simply need someone to refill their script. Okay. Oh, here we go. Oh, from Quan-Chan. Outside of high-risk individuals, the absolute risk reduction of cholesterol lowering appears small, as shown in HOPE-3 over 7 years of treatment. Well, you know, I thought it was pretty good. I mean, it was a decent reduction in risk. And I think, you know, the thing is 7 years is not very long. So if you have a 50-year-old man, I mean, 7 years is to the age of 57. I mean, that's like nothing at all. Really what we've seen with all of the statin trials, the longer the patient is on therapy, the greater the risk. So I think there'd be more concern if you have a treatment that has a lot of side effects, a treatment that's very expensive. Obviously, generic statin therapy is very inexpensive. And obviously, you know, you can prevent that event, not in 7 years, prevent that event in 15 or 20 years, then I would argue that it's cost effective. Yeah, so, yeah, okay. Okay, so it's not really necessary to have a fasting lipid profile to assess LDL or non-HDL. So the reason for fasting is that, you know, risk assessment, we're often measuring fasting glucose, a few other things. But the other reason for having non-fasting is for patients who have hypertriglyceridemia. So as I've emphasized, there's little benefit of adding a fibrate, but if the patient is running around with triglycerides of 5, then it's an indication to really, you know, talk about their lifestyle and make changes there. So, but in terms of risk, non-HDL, LDL, doesn't matter if they're fasting or not. You see the full effect of statin therapy in about 12 days. You see the full effect of qualitative changes in the diet. So reducing saturated fat intake, reducing cholesterol intake. You also see that in about 11 or 12 days. It's related to the half-life of the LDL particles. So you can measure actually very quickly. It's more having not necessary to bring the patient back in 2 weeks, but if they're not convinced that their medication is going to work, then actually you can do that. Question from David Burney. I see lots of patients who self-discontinue statin because of muscle pain with or without CK elevation. What is your approach? Okay, right. Well, we've had all sorts of good studies on statin intolerance. Is it real or is it not? So, and there's been sort of a really nice publication in Lancet or BMJ recently from the Emerging Risk Factors Collaboration. Across the board, if you really do a randomized controlled trial in patients who believe they're statin intolerant, across the board of those patients have actually tried multiple statins. If they're provided a statin in a blinded fashion, only about 10% can you reproduce symptoms when they actually are in a statin. So you're really dealing with this patient who is convinced. They're often talking to their neighbor across the street or to another family member, and they just have this bee in their bonnet that they're intolerant. So, you know, it is a challenge. I often put these patients on pravastatin simply because I can give them this good spin, you know, taking a bad time, cleared by morning, half-life's very short, not lipid soluble theoretically. You know, this is not going to get into your brain, into your muscles, into your joints. So, you know, we'll start slowly and build up. So I think the other issue in that is patients are frightened. So the patients who don't tolerate statins are terrified. They've got some aches and pains in their muscles. They think they're getting rhabdomyolysis. Their muscles are going to fade away. You have to try to convince them, like everybody has muscle aches and pains. And even if it is due to your statin, it's not going to kill you. I mean, it's this sort of thing. Of course, that is in the background of the few cases of rhabdo that I actually see. So it's a difficult thing. You know, I've been doing this for many years. In 1988, when I was working in the lipid clinic at St. Mike's with Alec Little, in those days we had to treat these patients with niacin and cholestyramine. Cholestyramine was 24 grams a day of that horrible powder, and we used to put them on 3 grams of niacin, so they flushed red as a beet. Those patients, once the first statin came along, which was lovastatin or Mevacor, probably the most toxic of any statin, nobody had side effects. Nobody had side effects. Yes. Yeah. But now, I mean, it's like everything else. It's all what's there in Dr. Google and so on. So it's difficult. Yeah. Dr. Nair, is rosuvastatin superior to atorvastatin? Rosuvastatin is superior in terms of efficacy. You do a little bit better with 40 of rosuvastatin than 80 of atorvastatin. It is less lipid, rosuvastatin is not really lipid soluble, so it should theoretically be better tolerated. I mean, they're both good drugs. There's a lot of controversy about statins and cognitive function, Alzheimer's, and of course, we think most cognitive function is really, you know, a lot of it is vascular dementia, so you want to reduce risk factors. But atorvastatin does cross the blood-brain barrier to a small effect for better or worse, whereas rosuvastatin doesn't. Yeah.
Non-cardiac chest pain, we do CT or PET-CT, and we find that there's either calcification or there's non-obstructive CVD. So are they now, should they be now primary or secondary prevention?
Well, you know, I think there was secondary prevention. Depends a little bit. You know, if that patient's 80 years old, it's quite different than if that patient is 50. So, you know, basically the lower you get the LDL, the better they'll do. So even in Jupiter, and Jupiter is a really neat study because it was rosuvastatin 20 and it was based in CRP, but basically it's an LDL study. In Jupiter, the patients who achieved an LDL below 1.3 by far did the best. So really, they well over a 50% reduction in future risk. So if you've got, you know, that 50-year-old who's got coronary artery calcium or a little bit of plaque, yeah, I would, if they tolerate it, I would treat them to LDLs definitely below 1.8. Yeah.
About focusing that.
Mm-hmm. Right. Right.
Yeah, it's cool. And we have seen, we don't know, it's placebo, increases in CK, like a fair bit.
Yeah.
And we're on cold flow, but we don't know.
We don't know whether it's colchicine or the other. Okay. Well, it wasn't seen in either Colcott or Lodoko or Lodoko 2. And there was a meta-analysis published in the European Heart Journal not too long ago and didn't see anything there. So CKs, a lot of people get concerned about CKs. So, you know, the guy, basically CK is consistently more than 10 times the upper limit of normal, we're concerned. If CK is greater than 5 times the upper limit of normal on repeat testing in patient with unexplained muscle symptoms, then, you know, we become concerned, particularly if that patient is diabetes or chronic kidney disease. You know, CKs that run around, you know, 400, 600, otherwise healthy patient, I'm not too concerned. Sometimes they have to be followed. I think the myositis is really more of the high risk patient with comorbidities. So, but yeah, but there was no myositis reported in those studies. Yeah. Well, you know, the calcium isn't what's going to give them problems across the board, but the calcium is really an indication of underlying plaque. So a coronary calcium score, I mean, it's not really a great measure, but you know, it's something that can be added in terms of risk assessment and primary prevention. Really less useful than a full CTA where you can have some idea of the amount of plaque. So I think for obviously patients who are athletes can still get coronary disease and they get pretty bad coronary disease. So it really depends. You're talking about like a 50-year-old who's a runner and yeah. Yeah, well, I don't know. If they have coronary calcium, I would treat them. Yeah. Yeah, the funny thing is statin therapy obviously reduces the plaque. It doesn't reduce the calcium. So, you know. The calcium isn't something we really follow. The calcium is kind of like that marker of risk. Oh, one more question here. What is your approach to statin use and statin selection in women of reproductive age? Okay, well, so we stop statins during pregnancy. Well, we stop like almost everything during pregnancy. The truth is we have post hoc data of patients who've gone through a pregnancy, taking their statin, either not knowing they're pregnant or not knowing they should stop it. And the data in terms of effects and the incidence of any fetal abnormalities is extraordinarily low. The increased risk is like 1.3. So statins probably are safe in pregnancy, but we stop them anyway. So I have a patient, young patient with FH, comes in with an LDL of 7, needs a statin. I tell them, you know, when they plan to get pregnant, stop it, start 3 months after after 3 months of lactation. But, you know, I've had this one patient, really bad coronary disease in a 27-year-old woman with FH. She had difficulty getting pregnant. She was in the fertility clinic. I told her, keep taking your statin until you have a positive pregnancy test and then stop it. So that's reasonable. So it's less of a concern than we used to think it was because these are not really teratogenic medications.
Thank you so much, Ruth. That was just exceptional. Excellent overview, and I always learn a lot from your talks. So thank you so much. That brings us to the end of rounds. Please join us next week. Quentin Berry is going to be giving us a presentation on revascularization in ischemic cardiomyopathy. So we'll see you next week. Thanks for joining.